can now maybe hear in the background the migrating parrots where I live, screeching in the background. They, like clockwork, migrate at 8 and now at 9. Apparently escaped from some pet shop or something during a fire many years ago and actually adapted to the desert. So in the morning, it's extraordinary. You see this flock of green parrots. The neighbors don't like them. They're really loud if you can hear them, but I think it's kind of amazing to hear and see tropical birds in the desert. Anyway, nice to see everyone for Neurology Morning Report today. And before we get started, well, if anyone has a case or if anyone was hoping to discuss the case, please identify yourselves in the chat. And while we're waiting for that, just to, Maria, do you want to announce the incredible generosity of our community to support Doctors Without Borders from the fundraiser last week?
Yes, hi everyone. On Friday, we had a very special fundraiser. We had our concert at VMRs. We actually had 4 VMRs. They're all posted on YouTube and on our website if you want to go check it out. And so we had 4 VMRs by RLR, Aaron, Charmaine and Jack, and Stefan Savin. And at the end of the day, we had raised like $4,000. And now we have we ended up with a total of like $7,600 on Sunday. So this is the power of our amazing community, and it wouldn't be possible without like all of you who come here every day and have fun with us. But we also learn so much about like the world outside of medicine. Like there is no world outside of medicine, and there's no medicine without the world. It's just like intertwined. So yeah, thank you for letting me share the good news with everyone here.
Yeah, well, thank you, Maria and Sukriti, who's not here, for organizing that way for this group to try to raise some funds for what's going on, and a pretty impressive amount of funds were raised. So thank you all for that. Anyone bring a case today they were hoping to discuss or present? And then we would like 2 discussants, ideally one identifying as a woman and one identifying as a man. Does anyone have a case they were hoping to present? Valeria, do you have a case by chance? I know you often have cases lately. If not, no worries. I'm sure a case will materialize. Was anyone hoping to discuss today? Or maybe not hoping to discuss, but now thinking they might like to discuss? Any newly matched neurology, soon to be neurology residents? Not to put you on the spot. Anyone? Are people just coming to watch me stall for a few minutes until somebody volunteers? The parrots will be gone soon. There will be no more entertainment of parrots by parrots. Please, would someone like to discuss? I think Maria is going to find us a human DX case. So we need 2 people to discuss that case while Maria finds one for us. Okay, we have one volunteer. Hans has discussed multiple times, but happy to have you again. Now that Hans has courageously joined, someone like to join him? Ideally, someone identifying as a woman. Dion, you have a case? Yeah, I think Maria found one, Dion. So if you want more time, we can have your case next week. Is totally fine, or if you want to present today, either way. Anyone like to discuss with Hans? He feels lonely there, discussing by himself. Maria and Hans, why don't you introduce yourselves to inspire the 3rd member of your fearless team?
You can go first.
Well, I discussed several times before. My name is Hans, and I graduated from Ross University. Yes, I'm still in the CARMS. I'm hoping to match.
Great. Thanks, Hans. Who would like to join Hans today? Maria, inspire them.
Ooh, I think Hans already inspired Diane, and I'm just going to introduce myself real fast.
Oh,
My
okay.
name is Maria. I'm in Guatemala, and I can't wait to present this case. It's a human DX one, but it looks really good. So
Okay, I hope we haven't done it before. No, okay, good. Dion, look, Dion and Hans are both repeat discussants. They had so much fun in previous times. They want to do it again. So they will inspire you to want to join next week. Do you want to just introduce yourself to this group, Dion?
I'm Diane. I'm a doctor. I'm in Haiti. I did internal medicine and then 1 year in neurology at New Valley. So happy to be discussing today.
Great to have you back. Thanks for joining us from Haiti. And go ahead. Do we have someone scribing and all that stuff set up? That's okay. In the meantime, do you want to just tell us the chief concern while we get that set up, Maria, and then Dion and Hans and I will start discussing.
yeah, so it goes progressively more confused.
Progressively more confused.
Yeah, I'm sorry, I'm trying to read it. Yeah, but confusion. Let's go with confusion.
Confusion. Okay. Dion, when you hear confusion, what comes to mind for you?
Confusion. Well, when did it start? For sure. Did it start abruptly, or was, oh, well, she already said progressive, so we know it was probably not something that was abrupt onset. What do they mean by confusion? Is it that they're speaking, they have a language problem? Is it that they're not understanding properly? Like, is it what type of confusion are we exactly talking about? What else? Are there any other symptoms associated to it? Is there fever? Is there, I don't know, like an episode of maybe seizure that they had before, or loss of consciousness that happened before too? Yeah, any past medical history? Is it the first time that it happened, or is it something that is happening for the second or third time? Yeah.
Brilliant. Dion, I agree completely, right? So she asked a very important question. What is meant by confusion, right? And so is this a global process, a truly global confusion that we can't tease apart further? Or as Dion said, if the patient had a language problem, someone might think they're confused, a Wernicke's aphasia, something like that, but they may not be confused, just their language may be impaired. Similarly, patients with amnesia, right, may appear very confused, but it's actually a focal deficit in memory, right? It would be very confusing to have no memory, to have anterograde amnesia, right? So we'll have to tease apart, is this a global process impacting kind of cognition globally, or is this a focal process impacting one module of cognition that gives the sense of something global? And then, as she said, of course, once we normally talk about localization and time course right here, confusion, we know we're in the brain, we don't have to figure out where along the nervous system we are. And then the time course is going to be very key here as well. Hans, what are you thinking when you hear about confusion in addition? And then I'll add some things as well.
Yes, we already mentioned the time course and global and focal. I was thinking maybe there is a metabolic problem, just like the mist, that gradually some electrolyte disorders might cause confusion, like hypercalcemia. Then I was thinking about gradually encroaching dementia for the patient. Maybe that could be a source of confusion. And then, of course, Diane already mentioned the possibility of maybe some infection or other things that might be the source of confusion.
Yeah, excellent. So I think what Diane and Hans are both pointing out here is that we're in neurology, morning report, and Maria searched specifically for neurology case. So presumably there's a neurological diagnosis here, but in the real world, most of the time when neurologists are consulted for confusion, both in the inpatient and outpatient settings, Yeah, I'll stand by that statement. I would say most of the time, the cause is not neurological in the sense of a primary neurologic disease, right? So zooming out, when I hear confusion, altered mental status, those types of chief concerns, my first question in my mind is this medical, neurological, or psychiatric, right? And so there's a long list of medical conditions that can cause confusion, right? The brain itself is structurally normal and functionally normal in principle, but something about the bad humors of uremia or hepatic disease or a medication or a severe systemic infection or a high fever, or just open up Harrison's textbook, flip through the pages and put your finger down and you'll find a cause of confusion, right? Because any of the systemic organs, what's their purpose? To get the brain, to keep the brain healthy, right? Is the whole point of all of those organs in many ways. So any defect in those can cause a medical cause of confusion. And then when we get into neurology, well, it's the whole differential diagnosis of anything that could affect the brain. And as Dion said, the time course is going to be key there. If this was sudden onset confusion, as she mentioned, is this a stroke? Is this a seizure? Or sometimes the seizure is short, unwitnessed, and the patient is found confused. Is it a postictal state, right? If this is confusion that's emerging over maybe a few hours to days, is this some type of infection, as Hans said, a meningitis, an encephalitis, an epidural abscess, intraparenchymal cerebral abscess, etc. If this is happening even more subacutely, but not entirely chronically, inflammatory conditions like antibody-mediated syndromes or paraneoplastic syndromes would come to mind. And then, as Hans said, if it's truly chronic, would we think about a neurodegenerative dementia? But even those chronic cases where the presentation is dementia, remember, dementia is a syndrome, not a disease, a syndrome of cognitive impairment sufficient to cause impaired activities of daily living. And that has a differential diagnosis. We hope in those patients we're going to find something reversible, because if they have Alzheimer's or dementia with Lewy bodies or frontotemporal dementia or vascular dementia, we are not going to be able to do too much about that at this stage in the history of medicine. But if we can find severe B12 deficiency, hypothyroidism, depression, normal pressure hydrocephalus, a large subdural hematoma, a meningioma pressing on the frontal lobe, et cetera, we might find a reversible cause of dementia. And I don't think I think I saw this patient at Mirebalais before you were there, Dion, but the psychiatrist sent a patient over to neurology for what they thought was presumed was dementia, because the patient had progressive cognitive neuropsychiatric dysfunction in older age. And part of the workup for that, as we'll probably talk about today, is getting some brain imaging to see what's going on. And the patient had a huge subdural. It was almost like the subdural there was taking up more space in the brain than the skull. And remember, subdural is venous bleeding, so it emerges and evolves very slowly, and gave the impression of a degenerative dementia from a totally treatable condition of subdural hematoma. So I'm not saying that's what's going on here, but just to show you all the many reversible causes of dementia that can be neoplastic or inflammatory or structural. Big picture, is this medical, neurologic, or psychiatric? Medical, the list is long. Neurologic, what is the time course? Is sort of how I start thinking about the chief concern of confusion, altered mental status, et cetera. Okay, Dion posed a lot of questions she'd like to know the answers to in the history. Let's see if Maria will be able to reveal those to us.
Doing great. I just want to know that I know the final diagnosis, but I know nothing about what I'm reading. So it's going to be exciting. Over the past 2 months, the patient has become progressively more confused with associated fatigue and generalized weakness. He first described the confusion as increased forgetfulness. And today he was brought by his daughter to the hospital with 1 week ago, he was brought by his daughter to the hospital because of overwhelming weakness, an acute worsening of his confusion, and she described it as nonsensical response to simple questions, as well as the inability to maintain eye contact and attention. Over the past year, he has had 50 pounds of unintentional weight loss, and he was recently admitted 1 month ago with Clostridium diarrhea, for which he was still taking oral vancomycin. Her daughter also says that he had previously reported a headache. And since initiating treatment with vancomycin, he no longer has diarrhea.
Okay.
Interesting.
And do you have the age of the patient, Maria?
Ooh, yeah. He is 69 years old.
69 with 2 months of progressive forgetfulness and weakness with an acute exacerbation, and some C. difficile diarrhea treated with vancomycin. Is that the arc of it? Okay, great. Hans, you're up. What do you think of what's going on here?
Now, when I looked at the symptoms, fatigue, forgetfulness, weakness, and of course, there is weight loss mentioned as well. I wasn't sure, I was thinking about something malignant or more medical, but of course, this is a neurological problem. But my first thought was weight loss, maybe there is some malignancy going on and we have a paraneoplastic syndrome, and that could in turn cause some autoantibodies causing a havoc in the brain. We've seen quite a few of those in earlier sessions. Another thing would be a metabolic derangement as well. That could cause weakness, forgetfulness. I'm not thinking too much about infection. We shall see when we have the vitals, whether we get a clue and later on in the CBC. So those are the things that came to my mind. Of course, it's also possible that he has some kind of dementia maybe that could cause the state of confusion and weight loss. People developing Alzheimer's occasionally or might lose some weight as well and behave in this way. And weakness is just a consequence of losing too much weight. So it could be secondary to something else like weight loss.
Yeah, very good thoughts. Yeah, it's hard not to think about cancer, right, in a patient of this age with this very severe weight loss. And then the question would be, which cancer and how is it affecting the brain? Primary cerebral tumors or intracranial tumors shouldn't in principle cause all this weight loss, right, unless the patient is not eating because they're dysphagic or so depressed, or their mental status is so depressed from that. But as you said, a systemic cancer by way of a paraneoplastic syndrome could cause confusion, antibody-mediated encephalitis, right? Or the cancer could have metastasized to the brain. You might say, wouldn't they have a focal syndrome of some sort? But there is a headache here, I think Maria mentioned. And if there a lot of the systemic cancers, when they metastasize, it's multifocal, small lesions at the gray-white junction. And there may not be an obvious focal deficit, but just the kind of network disruption that happens from having so many small lesions could give a sort of more global picture. So I agree with you on that sense. You mentioned probably not an infection. I guess the only infection I would could think of that would be going on for this long and cause this progressive dysfunction without, and the patient is still alive, right? This is not bacterial meningitis. This is not viral encephalitis, right? But going on for months. Does the patient have undiagnosed HIV infection, right? And has some intracranial disease from that opportunistic infection or otherwise, and maybe the diarrhea is also related to that. And C. diff is maybe not to be taken at face value, but just hearing chronic weight loss with confusion, diarrhea, that was another thing that ran through my mind. Does this patient have undiagnosed HIV? Other thoughts, Dion, and then I'll add some things.
I mean, I wouldn't completely rule out the infection just because his immune system is not probably the best right now. So even though they didn't mention fever or anything else, it could be like a chronic infection, like someone mentioned in the chat, chronic meningitis. I don't know if TB is common where she is, but that could be like TB meningitis, even though they never mentioned anything about coughing before, or that could make us think about TB. But yeah, for me, like the infection is still in the picture because we don't have enough information to rule it out.
Yeah, I agree, right? So when we think about meningitis, we think of acute meningitis. That's bacterial and viral meningitis, but you can get a more subacute meningitis with tuberculosis, and in places where there's a high burden of tuberculosis, like Haiti, where Dion works and where I have spent some time working with Dion and her colleagues, there's so much tuberculosis that it's obviously much higher on the differential for almost any presentation. We've seen pancreatic TB and anything TB, tuberculomas and tuberculous meningitis and tuberculous arachnoiditis causing cauda equina syndrome and Pott's disease and all these things, right? So a subacute to chronic meningitis you can see with tuberculosis, you can see with some fungal infections, and the endemic mycoses, cocci and blasto and histo, you don't need to be immunocompromised to get those. Usually there's concurrent pulmonary disease, but not necessarily. And as Dion said, for TB, I think it's about 50% of the time that patients have just pure neurologic TB or pure extra pulmonary TB with no clear pulmonary footprint there. So yeah, whether some are chronic or subacute infections, TB, HIV, syphilis, could probably be on the differential too. As far as if we end up, well, let me back up. So Hans made an interesting point, right? Could this patient have dementia? Moving along for 2 months, if the patient was truly normal 2 months ago, that would maybe make it a little less likely that this patient has a neurodegenerative dementia, but some patients have some underlying dementia, and depending how they spend their days, right, it might not be obvious to them or the people around them, right? So if we don't know about this person, if they're maybe retired and not very active and watching TV and having some chats with their family and don't have too many appointments to remember, right, or too many places to drive to or a job to do, it might not be obvious that their cognition is declining until they have some medical illness superimposed on that, and then they sort of fall off the edge of the cliff. We see this a lot in neurology where we're consulted and they say the patient woke up from their colonoscopy with Alzheimer's disease. And we say, no, it doesn't work like that, right? This is a chronic disease. Or the patient woke up from their surgery with Alzheimer's disease. And we say, no, it doesn't work like that. And when you really get a good history, it seems like, well, they retired a little early because they didn't feel like they were doing as well at work. And you realize there's actually a history of decline here and something acute sort of tipped things over the edge. So that's a good thought, Hans, that there's a chronic dementia here, and whatever is superimposed, some type of infection could have set it off. I think, yeah, there's some interesting features here. If you told me the patient was truly normal 2 months ago and has sort of a subacute development of a neurologic syndrome, at this age group, it'd be hard not to think about cancer in one or more ways, right? A paraneoplastic or metastases to the brain. We'd have to want to rule out, right, B12 deficiency, TSH, hypothyroidism, renal failure, hepatic failure, all the medical things, any medications, drugs, alcohol, et cetera, that could be causing change in cognition as well. I don't know too much what to do about the diarrhea, and if it's truly C. diff, and okay, that happens, and how it's related. There's so many antibody-mediated syndromes now. We talked about this on Friday, right? I'm revising my book for the second edition. I had a 1-page table of all the antibody-mediated syndromes. 5 years later, it's a 2-page table. And so I'm still catching up. There is one anti-DPPX, which has, I think, diarrhea and I think some encephalopathy, and I think has, I think there's a hyperkinetic movement. I can't keep track of them. There's so many of them now. But yeah, we as we talked about on Friday, we would like to diagnose these conditions because they're new, they're interesting, and they're treatable, but we get biased a little bit to them, and they're not necessarily that common. But just trying to dig through the history here, this patient has something going on and then seems to have something abrupt happen on top of that. So what is that abrupt event? When we think about abrupt events in neurology, just removing that word abrupt, right? Is there a stroke or a seizure? And is that something new superimposed on something old, like a chronic dementing illness? Or is there some ongoing process of smaller strokes and now the patient has had a bigger one? If the patient has atrial fibrillation, common things being common. If the patient has some type of subacute endocarditis, the patient has a cardiac tumor, like a myxoma or a fibroelastoma, and is throwing things off to the brain. Or then we could get into rare stuff, a headache, strokes, and confusion. You could think about CNS vasculitis, which can be primary. meaning specific to the CNS vasculature. It could be secondary to a systemic rheumatologic disease that also causes a vasculitis. It can be secondary to infection, syphilitic, meningovascular syphilis, aspergillus, mucormycosis, all things that can cause vasculitis, VZV, even without the rash. Intravascular lymphoma, if we get into super rare stuff that sort of keeps causing small strokes, sort of superimposing themselves on top of each other. Or if we toss the stroke hypothesis and say, well, if something sudden happened, did the patient go into some type of non-convulsive seizures? That would push us, I think, back towards maybe one of these antibody-mediated conditions, because they often affect the limbic system, which is the medial temporal, includes the medial temporal regions, which for whatever reason, when they're involved in a disease, can be epileptogenic. So we have a lot of hypotheses still here, right? Is this a dementing illness with a superimposed medical condition causing the patient to tip over? Is this a subacute inflammatory condition, like a paraneoplastic condition or a neoplastic condition with metastases? Or is this some process that's having superimposed acute events, giving a sort of illusion of subacuteness, but it's actually multiple acute events, such as something causing recurrent strokes or something causing seizure, postictal state, seizure, postictal state, seizure, postictal state. So we're sort of still in all the potential categories of differential diagnosis here. We'll hear the exam. Diana, I was going to ask you to discuss the exam. So what are you looking for in particular that might help us out here in moving forward?
I'm sorry, Aaron. My internet connection is acting up.
Oh, can you still hear us?
What did you ask?
Oh, I was asking you, we're going to hear the exam. What are you looking for in particular on the exam that might help us narrow the differential diagnosis here?
I hope you can hear me well.
Yes, we can hear you.
Okay, perfect. So you asked what am I looking for in the physical exam?
Yeah, what are you looking for on the physical exam exactly?
So definitely the mental status exam is something that I look forward to seeing, like to be able to know exactly where the problem is. If it's an attention problem, if it's something that has to do with the language, if it's something that has to do with the memory, like if we're thinking dementia, it could help us know if it's like just one domain or multiple domain for the dementia. Definitely for the I would want to know if there are any other associated symptoms, like if there is what's it called, there are focal deficits, if there is a problem with the sensitivity somewhere, the cranial nerve exam. There's not much that I would be looking forward looking at it, to be honest. And what else? The reflexes. It could help with B12 deficiency to have, and other diagnosis too, to have the reflexes to see if it's hyperreflexia or normal reflexes. And yeah, that's
perfect. I agree with you. Of course, we'll do a complete neurologic exam, but as far as the hypothesis-driven part, we really want to characterize this patient's mental state. Do they have a global sort of delirious encephalopathy kind of picture where their attention is impaired, they can't really keep track of the conversation, they can't really keep track of the exam? And once attention is impaired, we've talked about this before, right? That's the first doorway into cognition. If you can't pay attention, you can't form a memory, you can't have a meaningful conversation. Or is there something focal? I've seen patients diagnosed as delirious, and when you really tease it apart, you see they're amnestic, right? Or they're aphasic, as we've talked about. So I think that's right. We'll want to better clarify what modality or modalities of cognition are impaired. Is this focal, multifocal, or global? And then the rest of the exam, I agree. If there's something there, we're going to be really rethinking our hypothesis, right? And if there's not, then we're sort of mostly focused on the mental status exam. Just one other thing that flew through my mind when you said the word cranial nerves, the time course doesn't fit here, but if you heard about a GI illness and then a very severe meningitis, listeria can cause a rhombencephalitis, a brainstem encephalitis. I've never seen this, but has been reported. And so presumably there would be some GI stuff. That's how the patient is getting the listeria. But I think it's a very acute disease, not something that's been going on for 2 months. Okay, we were stalling for you, Maria. Can you tell us the physical exam?
I'm so sorry.
No, perfect timing.
You know, just as Diane was saying, we have so much TB right now. I got like new forms to send people for TB. So that's why I had like TB exists in the world. I'm going to give you the past history, past medical history.
Thank you.
He has alcoholic cirrhosis and had a liver kidney transplant 8 years prior. He has diverticulitis, hypertension, and recurrent C. diff infections. His family history, he has a mother with dementia and a father with heart failure. For social history, has not drank alcohol for 10 years, but previously he had substance abuse disorder. He occasionally smokes cigars, but no illicit drug use. And on medications, he has amlodipine, carvedilol, mycophenolate, prednisone, trimethoprim sulfa, MWF, don't know what that is, tacrolimus, thiamine, and vancomycin.
MWF or MMF?
MWF.
Is it supposed to be mycophenolate mofetil? But I don't know where the W is. Okay,
Well,
tacrolimus at least.
Also on mycophenolate. I'm gonna write the meds right now. Do you wanna sort of discuss this, or do you want me to keep going?
Yeah, so I guess usually we hear in the chief concern some of this past medical history. So that is something to discuss. And we have a very important new element here, and it's not the diverticulitis, right? So organ transplantation and tacrolimus, how does that change our thinking here? Hans or Dion, feel free to chime in.
Now with organ transplantation, I'm right away thinking about an immunocompromised state, which is similar to HIV. So now we have the possibility, is it called PML, something like this, like a reactivation of the JC virus. It could be something else in the brain, like primary lymphoma, something like this. And of course, infections in general might have to be considered as well. So malignancy and infection are on the table.
Absolutely. If we had heard immunocompromised post-transplant in the chief concern, right, our discussion of all these things would have changed its ordering, right, to differential diagnosis, infection, 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 and then the other things, right? And it's important to know that in patients who are immunocompromised, that the neurologic infections, any infection, but we're talking about neurologic infections, can present somewhat atypically, because a lot of the symptoms and signs of an infection are due to the inflammation, right? So meningismus is inflammation of the meninges. A patient who's very immunocompromised, well, they might not be able to generate much of an inflammatory response. The meninges might not be meningitic, right? There might not be nuchal rigidity. Patient might not mount a fever because we're suppressing the very immune system that would generate the fever. The spinal fluid can be unimpressive. If you have a peripheral white count of point something, right? You don't have too many cells to spare to spill into the cerebrospinal fluid. So it's hard. It would be hard to pull away. So I'm glad we had our discussion before we knew that to talk about altered mental status, but knowing that, it's hard to pull away from an infection. And Hans mentioned some interesting possibilities there, including PML, which is reactivation of JC virus. And that's actually a reasonably good fit for this sort of subacute, kind of multifocal white matter disease. The acute sort of event on top of things would maybe not square so well with PML, but we still are maybe not entirely clear what's meant by that in the history. And then toxoplasmosis and CNS lymphoma, post-transplant lymphoproliferative disease. And then we have a long med list here, right? So we also have to think about medication toxicities. Any medications on that list jump out to either of you as potentially neurotoxic? Hans or Dion, any thoughts on the medication list?
When I was looking at this TMP SMX with folic acid, but this doesn't affect the brain. We have carvedilol, amlodipine, mycophenolate, and tacrolimus are immunosuppressants. Thiamine, and now I don't know which one might affect the brain somehow.
Yeah, Dion, any thoughts here?
I do not know either.
No problem. Yeah,
I would
so
want to look up for tacrolimus, but I don't know.
yep, you're on the right track. Yeah, so tacrolimus, the most common neurologic symptom is a tremor. It's usually a very coarse, bilateral, very high frequency, moderate amplitude tremor. And the patient doesn't have to be toxic on tacrolimus, but I did my intern year in a place with a large bone marrow transplant service where a large role of the senior resident, fortunately not me as the intern, was to titrate the tacrolimus levels every day, because these are some of the sickest patients you'll ever see. They've undergone a bone marrow transplant, or they're about to undergo one, so they have no bone marrow, and they're, no one can bring flowers because any potential bacteria. We had an outbreak of Bacillus cereus meningitis that was ultimately found to be spores in the pillowcases from the laundry room. These are incredibly, patients with incredibly delicate physiology, and they get extremely, extremely sick. But one thing for me as a future neurologist was noticing that they all have a tremor when they're on tacrolimus. Tacrolimus can also cause PRES, posterior reversible encephalopathy syndrome, which can be caused by hypertension, by eclampsia, and by a number of medications, including tacrolimus. That's usually acute. But does this patient have something chronic going on and then something acute going on top of it? And I think I solved the MWF mystery. That was, it must be getting Bactrim 3 days a week as their prophylaxis Monday, Wednesday, and Friday. Mycophenolate, I don't think of any neurologic toxicity with that. And then I guess the other thing is, what if these transplants are failing and the patient is now uremic and or encephalopathic from hepatopathy? Okay, so that was a big aliquot, actually a small aliquot with big implications for us, right? So what did we find on the physical exam, Maria, if you're available? I see you're running a clinic as well.
I'm available, but we have a lot of things because it, like human DX cases, they're very typical for internal medicine. So let's see. Vital signs 30, afebrile, heart rate 75, vital signs normal. He's cachectic, and extremely chronically ill appearing. And for the neuro part, he's somnolent but opens eyes and follows basic commands like squeezing the hands, although not reliably. Grimaces to noxious stimuli throughout all extremities, is unable to sustain anti-gravity when bilateral upper extremities are lifted. He has 2+ reflexes diffusely, no clonus, no rigidity, no asterixis, and only answers yes or no to questions. And that's what we have.
That's it. So somnolent, minimally participatory in the exam, no asterixis is basically the summary. So Dion, what do you do with this exam? Does it help us narrow our differential? And what do you want to do next?
I would want to know how, does it have ictal, like how are his eyes?
Does he have jaundice? Yeah, icterus. Jaundice. Yeah. No scleral icterus, Maria says.
Mm-hmm.
Yeah.
Mm-hmm.
Okay, good question. Yeah.
So basically there was not much on the neuro exam, to be honest.
Well, to answer your question that you asked before, does this look like a focal process to you or a global process to you?
It looks global to me.
This is a global process, right? Now, a global process could be many small lesions, right? But often a global process in a very medically ill patient would make us wonder if there's a medical etiology here, although Dion is an internist and a neurologist, unlike me, who just did a year of internal medicine. So she knew to look at the sclera and see what color they were, whereas I would have just been seeing if the eyes open or not and did the eyeballs move, and probably wouldn't have been paying too close attention to the color of them. So I agree, this is an exam that doesn't help us really much further, right? Even that the patient is afebrile doesn't help us, because as we said, with all that prednisone and tacrolimus and mycophenolate, the patient probably can't mount much of an inflammatory response. So what would you do next, Dion?
Definitely have like a complete metabolic panel. The CBC, I would check like all electrolytes. I would try to rule out infections too, like have a hemoculture if possible. Not sure about, oh, what about his neck? Was his neck like normal, or was it?
It's like not commented on, so we'll presume normal.
Yeah, normal. So I don't know. Definitely go to imaging also. And I only have CT and Haiti, so I would go for a CT, but CT or MRI would actually be better, but
yeah,
if no access to the MRI, definitely.
Yeah, very good. Yeah, so we definitely, I usually skip over the labs, right? But this is a case where the labs are going to be important to us, right? What is this patient's peripheral white count, and how is it related to previous white counts? And what's going on with the kidneys and liver? Are they working or not? Are there any, if the kidneys are not working, does this patient have a very high BUN, which is probably not causing the encephalopathy, but a biomarker for the fact that there's lots of bad humors floating around, similarly with the liver. But barring that, I agree. And even if we do see stuff there, probably going to need brain imaging. And yeah, CT would be the fastest thing to get. And this patient is pretty sick, somnolent, right? We didn't get to hear what, we didn't maybe have the information about what the pupils are doing and the corneals and all that stuff. But this patient is bordering on obtunded stuporous, getting toward coma, for someone who was presumably up and about 2 months ago. So probably a CT is going to be quick to get and just see, was there something obvious there? But yeah, an MRI, particularly with contrast, if the nephrologists think it's safe and okay to do, would give us a little more information. So, and then if we really don't, what if the imaging is unremarkable, the labs are unremarkable? What else, what other tests would you be thinking about here? Well, what else do we have left in neurology? We have imaging, spinal fluid, EEG, and EMG. Those are basically our tools. Any of the other ones you think could be helpful here?
EEG maybe. Yeah.
Yeah. One question is this somnolence and this fluctuating mental status over the past few months due to ongoing seizure activity? Not all seizure activity causes generalized tonic-clonic seizures. This entity of non-convulsive seizures, electrographic seizures without clear focal motor activity. There are some studies that suggest comatose patients in ICUs, up to 20% of them are actually having intermittent seizures. Whether that's the full explanation, how treating them really affects the prognosis, I think we still don't fully understand. So I think that would be helpful. And then probably if we really don't,
check for B12 levels too. I'm not sure I put it.
Yeah, B12 would be good to do too. And then probably if we don't have anything here, given the high suspicion for infection, we'd want to consider spinal fluid, right? And even spinal fluid parameters can be deceiving in patients who are immunocompromised, right? The white count might not be that impressive, the protein might not be that high, but if available, we can get cultures and PCRs and all that good stuff. Okay, Maria, so what all happened next in this big aliquot?
Okay, I'm gonna give you labs and the imaging. I know that Shannon, who is our amazing scribe for the day, is putting like WBC or VC and everything. We usually don't focus that much on the Neuro VMR. I don't know if that's a good thing or a bad thing, but white blood cell count was normal. All electrolytes were normal, including like liver, enzymes, bilirubin, alkalis, total protein, INR, PTT. Everything looked normal. Cortisol was normal, vitamin B12 was normal, tacrolimus level is normal, ammonia is normal as well. And for the imaging, he had a CT done 1 week ago, which was unremarkable, and an MRI with mild to moderate cerebral atrophy. Right. He had a CT CAP. That's
Chest,
chest,
abdomen,
pelvis, yeah, with everything consistent with how he previously had been. And the current imaging now, he had a CT brain with dilation of lateral third and fourth ventricles. An MRI of the brain had dilated ventricles, small acute infarction within the right temporal lobe, and small foci of restricted diffusion within the left cerebellar hemisphere. Leptomeningeal enhancement within the bilateral cerebellar hemispheres as well. And the EEG showed no epileptiform discharge or any seizure.
Okay, well, I'm glad you mentioned tacrolimus level. That was something that crossed my mind and I didn't get to say. Yeah, tacrolimus toxicity, I'm not sure, but I'm going to guess could make you confused as well. And I think I have one patient I remember, I think I was a medicine intern taking care of this patient. They were very confused, and the neurology service was consulted. I was still on the internal medicine side and kept saying tacrolimus can cause, I think it was tacrolimus, a chronic encephalopathy, and the bone marrow transplant people kept saying, no, we have millions of patients on this. It doesn't, you can't stop it. And the neurology team kept saying, stop it, switch to something else. And finally they, the guy hadn't woken up in weeks. And finally they stopped it for a few days. And I remember I went to do my usual shake the patient or whatever, and he just opened his eyes and said, get the F out of here. And I thought, oh, he is so much better. And it was, I believe, an example of chronic tacrolimus encephalopathy. Anyway, I'm glad you mentioned that because that should be on our list. However, the MRI is, I think, where some answers lie here. Whether it is the final answer is a little harder to say. So what do you make of this? There's hydrocephalus, leptomeningeal enhancement, and foci of restricted diffusion suggest infarction. So we have lots of different types of pathology that have been discussed so far, right? Ventricular pathology, meningeal pathology, and parenchymal pathology. So our sense of something subacute with acute things happening on top of it is sort of borne out by the story told by this MRI, that there are things that have been happening over an instant, sudden time course, the restricted diffusion piece, and things that are happening over a less sudden, but still seemingly subacute, relatively acute, right? Because we had a CT and MRI a week ago that were normal, and something has popped up in the meantime. So how do you take this to a final diagnosis? I think Hans, you're up. What do you think? What are you thinking, and what would be the next test you would order? And then Dion, you can say, and I'll say as well, and then we'll see what the answer is.
I'm not sure, but looking at the MRI, the most recent one for this patient, besides the dilated ventricles, the acute infarction in the brain, right, temporal lobe, and of course affecting the cerebral hemisphere, I was thinking about something like vascular affecting the brain, like a vascular dementia as a possibility, but I can't figure out the leptomeningeal enhancement. We once had it where we had a carcinoma, a meningeal carcinoma, and that could indeed cause everything that the patient showed, but I don't know the primary tumor either. So at this point, I'm still thinking everything, and I'm not sure what exactly the patient might have.
Yeah, so these terms I didn't know till I was a neurology resident, hadn't heard. There's the meninges, right? Dura, arachnoid, pia. And then there's these terms pachymeninges and leptomeninges. The pachymeninges, like pachyderm, elephant, thick skin, is the dura. Pachy is thick. And lepto, I don't know, is anyone Latin, Greek, whatever language that is lepto thin? I don't know. In any case, isn't lepto butterfly? Lepto something? Maybe it's thin? Anyway, someone in the chat will know the answer, I'm sure. But the leptomeninges are the arachnoid and pia. And so dural enhancement or pachymeningeal enhancement and leptomeningeal enhancement have slightly different differential diagnoses, although they're overlapping. You can see dural enhancement just from low CSF pressure after a spinal tap, totally normal finding as the veins dilate to sort of maintain pressure. You can see it from a chronic CSF leak. You can see it from dural metastases. You can see it from inflammatory conditions, inflammatory pachymeningitis, such as IgG4-related disease. And then leptomeningeal enhancement is what you usually see with infectious meningitis, though some conditions can cause pachy. And then inflammatory diseases straddle these. So rheumatoid arthritis-associated pachymeningitis, sarcoid-associated leptomeningeal findings. There's a great, Doug Pett did a recent consult question podcast for CP solvers. I won't spoil the diagnosis, but there's some leptomeningeal enhancement that's somewhat unexpected there as well. So, and you can see cancer in both places. Dural metastases, somewhat not uncommon in prostate and breast, and leptomeningeal metastases, as we saw a few weeks ago. I forget what the primary cancer was, but can be seen with any cancer as well. But if they weren't there a week ago and they're here now, that's to me pretty fast for cancer. So what would you do with the package of meningitis what would you do with the package of meningeal enhancement, stroke, and hydrocephalus? Dion, do those three add up to anything from your perspective?
I think if there is like any type of infection, like meningitis, we didn't do the LP, so I would definitely go ahead and do the LP to make sure there is no infection, because if there is one, we know that it could also explain the hydrocephalus. Like if there's the resorption of the CSF is going to be impaired because of the inflammation, and we know that it's through the arachnoids. I don't know how to say it in English.
You said it perfect. Arachnoid granulations. Yeah.
Granulation, exactly. So that could explain it. And I mean, it could also explain the small stroke.
I agree with you. How does it explain it? Because I think many people do not realize that a meningitis and stroke can go together.
I mean, anything that can, it will diminish the perfusion, because there is increase in the, because it's taking up space in the brain. The brain is closed with the skull. So if you have any inflammation, so it will take much more space, and then the blood vessels, there might be difficulty for the perfusion to be the same because of the intracranial pressure that might increase because of it. So that would be my explanation for the stroke.
Yeah, very good, right? So there's something going on in the meninges, and that can cause communicating hydrocephalus, as Dion explained, right? You have gumming up of the arachnoid granulations, and you can't reabsorb CSF, so all the ventricles dilate. Non-specific, we have a meningeal process. And then, because the blood vessels of the circle of Willis run through the subarachnoid space, which is surrounded by the meninges, right, arachnoid, meningitis of any type, including infectious meningitis, can cause a CNS vasculitis, a secondary vasculitis that can lead to infarct. So I think there's a study, I think from South Africa, looking at tuberculosis meningitis, and the package of hydrocephalus, meningeal enhancement, and deep infarction in the basal ganglia is has relatively high sensitivity specificity for TB meningitis. But cryptomeningitis can also do that. I think if this patient's really had this process for 2 months, well, they probably haven't, right? The imaging was normal a week ago, so they have something for a week now. But untreated bacterial meningitis for a week, well, maybe that vancomycin for the C. diff was giving them some partial coverage, and this is partially treated bacterial meningitis. But with this level of immunosuppression, it could really be anything, right? It could be fungal meningitis, could be tubercular meningitis if the patient has relevant exposures, as Dion mentioned earlier. Could be, so meningovascular syphilis can also do this, right? Part of early neurosyphilis, meningitis plus strokes. And then is this partially treated bacterial meningitis that the patient is doing okay for a week without full treatment, but is getting some treatment through this vancomycin for their C. diff. Whole thing doesn't really explain the chronic weight loss and all that. There is a syndrome. So the other possibility here is, does a patient have endocarditis, right? And has sent emboli both to the vasculature, causing small strokes, and seeded the meninges. There's a syndrome, I think it's Austrian syndrome, which is strep pneumo causing pneumonia, endocarditis, and meningitis together. It's Austrian, I think, was a person, not the country Austria. So probably an echocardiogram is helpful here. This patient has subacute endocarditis and everything's coming from the heart, and that's sort of the chronic thing, and the acute thing is the actual embolization. But this could really be anything, and I agree, cerebrospinal fluid is going to be very helpful to us here. The profile might fool you, right? If the CSF is normal, don't be fooled. The immunosuppression that is being given to the patient might not might cause the CSF not to be very impressive. The patient had a CT chest, abdomen, pelvis, right? So sometimes endocarditis, you can see clues of renal infarct or something like that. That'll give you a clue that something central is going on, but I'm not sure how sensitive that would be. Okay, so I would guess the final diagnosis is in the spinal fluid. And is it a cryptococcal antigen? Is it a gram stain? Is it a bacterial culture? I don't know the answer in this case. Oh, other things that we didn't mention. VZV can cause a vasculitis, a meningitis, and or an encephalitis. And the appropriate test in the CSF is actually the VZV IgG. The PCR is insensitive. And then this patient is very immunosuppressed, right? Aspergillus is angioinvasive and can cause meningitis with infarcts or just infarcts. And then mucormycosis can also be angioinvasive. You don't always have the sinus disease. So in the immunocompromised patient, a VZV vasculitis or a angioinvasive fungus, mucor, or aspergillus would also be on my differential, but it's going to be CSF to solve it, and could be any of those things. So Maria, did they get some spinal fluid, and what was in there?
Great, yeah, I'm gonna read everything. Just stop me if you wanna discuss or
Nope,
not.
get us all the way over the finish line. And
Okay.
well, okay, I say that, but then you'll say something. I'll say, no, stop.
Okay, just go. Okay, HIV negative, CD4 count 40, EBV, BCA, IgM negative, syphilis negative, blood cultures negative, and they did an LP with an opening pressure of 4.8 centimeters, a cell count of white blood cell count of 3 with lymphocytic predominance and 44 RBCs. Glucose was 8, protein 426. Then they did additional CSF studies, which revealed the diagnosis. So stop me now if you don't want to know it. Bacterial culture negative, fungal stain, budding yeast, and cryptococcal antigen positive. And that's it.
All right. Why? What's so funny about cryptococcus?
No, it's just like I just read the diagnosis and then I didn't know how many turns and twists the case had.
How many what? Sorry.
Like turns and twists that the case had. So now it's like, oh, okay, there's nothing left.
Here we are. Yeah. Right. So I don't think there would be anything specific about this presentation and imaging to tell you, except all signs pointing to infection. And I think the key teaching point there is to know that we all learned India ink. Although Dion can tell us in French, they call it encre de Chine, right? So it's Chinese ink in France, but it's India ink. I don't know why that, so maybe someone knows that history. Tinta China in Spanish, Maria is telling us as well. So I don't know why it's India ink somewhere and China ink elsewhere, but the important thing is it's not sensitive, right? So on step 1, fine, India ink positive, but in real life, not sensitive. And the CRAG or the cryptococcal antigen is really your most sensitive test for this diagnosis in the CSF. CSF culture for crypto is also sensitive, but it takes forever to grow, is my understanding. So the CRAG, if you have it available to you, is really the highest yield test here. Important to know, those of you practicing in places where you have the BioFire assay, I don't know how it got that cool name, the meningitis encephalitis BioFire, which is a multiplex PCR for something like 7 bacteria and a handful of viruses, and Cryptococcus neoformans, which is probably what this is, and Cryptococcus gattii, which is in the Pacific Northwest and can infect immunocompetent patients. People say, oh, we're getting the crypto test on there. No, it's the PCR. There's lots of false negatives. So the cryptococcal antigen is where the answer is. So Gee, I don't know if they tell you there, but good luck treating this patient with 2 transplants. And now we're going to have to give them amphotericin and fluconazole and really monitor carefully that we don't damage these precious transplanted grafts. But any follow-up or further thoughts that are there, Maria, or does it just end with the diagnosis?
No, it ends with sad news. So he was treated for cryptococcal meningitis with amphotericin flucytosine, but he did not tolerate flucytosine. So he was transitioned to amphotericin fluconazole, but no improvement in his mental status. His hospital course was complicated by aspiration pneumonia, septic shock, and acute hypoxemic respiratory failure requiring intubation, and he ultimately passed away while in the hospital.
Yeah, sorry to hear that. These are very challenging patients, right? They're very sick medically and then sick neurologically, and often the treatment for these infections is very toxic to the fragile organ grafts. And the patient is immunocompromised, and you're treating them for an opportunistic infection. If you take off the immunosuppressants, you're putting the grafts at risk, and then you risk a more fulminant inflammatory response, the iris response, right? So very difficult multidisciplinary infectious disease plus medicine plus neurology plus ICU type cases. The other just point about cryptococcal meningitis, if you've taken care of patients with this condition, their intracranial pressure can have huge swings in it. So I remember when I spent time in Malawi, patient would get a spinal tap. We'd see that it's cryptococcal meningitis, usually in the context of HIV there. Patient would be awake and talking to you. The next morning on rounds, they would be obtunded. You'd do a spinal tap on rounds, come back at the end of rounds, and they'd be awake again. And some of these patients need a lot of lumbar punctures to sort of get them, to bridge them to when the therapy kicks in. And some, they end up needing a VP shunt. And yeah, the opening pressure, I wonder if the 4.8 actually means 48. Some people report this differently. So I wonder if it's, let's call it 48. Yeah, because I don't think it would have been low with that hydrocephalus and cryptococcal meningitis. Anyway, wonderful. Wow, you really dug up a complicated case for us, Maria, but allowed us to talk about lots of things and learn late about the immunosuppression so we could keep a broad differential. Earlier, the parrots are applauding in the background. If you can't hear them, applauding for you, Dion and Hans, wonderful discussion. Maria, are those teaching points yours, or is there someone else? You're at full service today. You're scribing teaching points and presenting the case and running a very busy clinic in rural Guatemala. So Maria is...
As long as I don't have to discuss and can hear other people discuss, that's always.
Maria is a superhero. Okay, tell us your teaching points for today.
Yeah. I'm sorry if they're like a little bit hectic, but we started with confusion, which I really like that CC. The first branching point you have to think about is like, is this neurology versus non-neurological causes or psychological causes? And for non-neuro, we have the great mnemonic of mist, metabolic, infectious, toxins, structural. Well, I guess it includes a couple of neuro points to it. And then for confusion, you really want to be more specific on how you approach it. So put a name to it. What do they mean with confusion? Because that will hint you into sort of the if you can localize it, or if you think more of like a global problem or things like that. And also put a last name to it, which in this case is the timing. So you have hyperacute, acute, subacute, chronic, and all of these are going to have different etiologies for it. In this case, we had sort of like a subacute progressive course, and with that you can consider chronic infections, not the typical bacterial or viral meningitis, which are very acute, but HIV, TB, fungal, or JCV reactivation. Also think malignancy, and so with malignancy you can think about like paraneoplastic mets or hypercoagulability. Neurodegenerative is more on like the chronic side, but you can also think about it if it's progressive and toxins, or like for example alcohol, or medical situations like such as CKD, vitamin B12 deficiency, or thyroid issues. And then we had this huge turning point in the case, which was the immunocompromised status of the host, which is a huge gravitational pull. You always have to put that somewhere in your problem representation because it will change management and will change your diagnosis. And For it, you want to consider atypical infections and also reactivation of past infections that could have been silenced. And very important, you have to consider atypical inflammatory responses. So don't be fooled if you don't see a fever, don't be fooled if you don't see meningitis, or even like CSF can be not flashy at all, just because the host cannot mount a proper inflammatory response. And you also want to consider like the medications and that are making him immunocompromised. For example, in this case, we learned that tacrolimus can cause PRES and tremors. We then saw something very interesting in the MRI, which was leptomeningeal enhancement, which I've never thought about it that way, but you can have dural enhancement and leptomeningeal enhancement. And so like dura is pachymeninges, and you can have that enhanced for CSF leaks, dural metastases, or inflammatory processes. And for the leptomeninges, which includes the arachnoid and pia mater, you can have that enhanced, which can be caused by malignancies, infections, and inflammatory. And I really liked how Diane not only approached like the causes of the leptomeningeal enhancement, but also the complications of it. So you can think of the hydrocephalus as being a complication from that, because you get like the arachnoid granulations inflamed, which reduces CSF absorption, which causes communicating hydrocephalus. And you can also get stroke secondary to infections and inflammation of the blood vessels. And then finally, we did an LP, which revealed the final diagnosis of cryptococcal meningitis. And then for the LP, it might show high opening pressure because of blockage of CSF reabsorption secondary to fungi capsule. I don't know if it was a typo, but Diane actually had a very interesting hypothesis. Maybe it was the LP was done before, unlike the first imaging where it didn't show any inflammation. And then we don't know if it was during the first week or the second week. And then India ink or China ink, I don't know. I'll take time out of my day to find what's up with that, but India ink is not sensitive, so go for cryptand. And that's it.
Fantastic, wonderful teaching points and case presentation, Maria. Thanks again, Dion and Hans. And I wish you all a wonderful Tuesday. Come back next week and hope, as much as we love to hear Dion and Hans discuss, as they have many times, always happy to have new discussants, new presenters. And if anyone here is here 4 days after their match on Friday, many congratulations. Have a wonderful day, everyone.
Bye.